Hi there, welcome to this virtual lesson, BIS is it. We are going to talk about BIS monitoring, train of 4, and paralytics. We're going to look at troubleshooting, proper management, appropriate levels of sedation, and analyzing some numbers. So paralytics, how do they work? Your skeletal muscles, they contract after a nerve stimulates the motor end plate. The nerve doesn't actually touch the muscle. It releases acetylcholine from the vesicles in the axon. Acetylcholine is a neurotransmitter, and when it crosses the synaptic cleft and receptors on the postsynaptic muscle membrane pick up the acetylcholine, then your muscles contract. So there's two main classifications of paralytics. You have your non-depolarizing, which are the more familiar ones to us because that is your Vecuronium and your Nimbex. And then you have your depolarizing neuromuscular blockers, such as Succinylcholine. Neuromuscular blockers, they temporarily paralyze the patient by blocking acetylcholine at the neuromuscular junction, thus preventing voluntary contraction of the skeletal muscles. Both of these classes of medications actually work on the acetylcholine. They either compete with it or they imitate it. Your non-depolarizing neuromuscular blockers, again, that's your Vecuronium and your Nimbex, they actually compete with acetylcholine. They bind to the postsynaptic receptor on the muscle membrane. The drugs prevent the movement of the sodium into the muscle cells, thus preventing stimulation of the action potential within the skeletal muscle. Without this stimulation, your muscles cannot contract, and then paralysis then results. Depolarizing neuromuscular drugs. Actually, the only one that is FDA approved is Succinylcholine. The structure of Succinylcholine is such that it resembles two molecules of acetylcholine, so it actually imitates instead of competes with acetylcholine. The enzyme pseudocholinesterase removes the succinylcholine from the plasma. When administered Sux, it produces a short depolarizing contraction of all of your skeletal muscles, and so when contraction occurs, the patient may have, you may see, you may not, some transient twitching or generalized whole body jerk of skeletal muscles. Flaccid skeletal muscle paralysis quickly follows because the muscles remain depolarized and they cannot repolarize. So a couple other things about succinylcholine. One, if you remember, we talked about in conscious sedation class, we talked about a antidote for rigid chest or wooden chest syndrome. And succinylcholine, also known as a nicotine, is actually one thing you can use to reverse that, because by paralyzing them, you're able to do what you need to do with the patient, and their chest is no longer rigid. The other thing succinylcholine is very well known for is malignant hyperthermia. Patients tend to have a genetic predisposition for this, so this is why it is extremely important to ask a patient before any surgery procedures if they have a history of, or their family members have a history of malignant hyperthermia. Now, in one of the care camps, somebody did ask me if there was a reversal for succinylcholine, and there's a very long answer to that, but the short answer is no. So why would we even think about choosing a paralytic? Well, let's think about the types of patients that you typically would see on the paralytic. Well, one, hypothermia protocol. Why do we use it with hypothermia protocol? Because it helps prevent shivering. The muscles cannot respond to the cold temperature. They cannot shiver, so they cannot generate heat. That we use paralytics for induction of hypothermia protocol. ARDS. ARDS is another one that we see. So we paralyze the patient because they're doing what we call bucking the vent, and not allowing the mechanical ventilator to do what it needs to do for the patient. So by paralyzing them, we can fully reap the benefits of the ventilator. Paralytics, they aid in gas exchange, allowing you as the nurse or the physician to adjust settings on the mechanical ventilator, whereas when the patient was not paralyzed and in ARDS, we were struggling to ventilate them. It also maximizes the patient's oxygen supply and demand to promote adequate tissue oxygenation. With therapeutic paralysis, the work of breathing is completely controlled by your ventilator instead of the patient's drive controlling it. So this leaves the patient unable to breathe independently, but facilitating improved gas exchange. Other kinds of patients that you could possibly see a paralytic on. Probably would see these patients in the STICU, and even some patients in CV-ICU. So if you have a patient with an open abdomen who's just going to go back to surgery the next day, they just put the drape on them, the tegaderm-ish drape on them so they could go back to surgery the next day. They'll put them on a paralytic so they don't move. Or the patient with an open chest after open heart, they had to crack the chest open because of tamponade or some other cause. So they will also paralyze them because any extraneous movements can have a detrimental effect on them. Condition number 4 would be patients who have increased ICP. In order to keep their ICP down, they could paralyze them. Often we do not see that in our surgical trauma ICU, or even in the ICU rather. Usually the neurosurgeons and the neurologists want to get a true picture of what the patient's doing neurologically, so they will usually not put them on a paralytic. So the goals of paralytic drug therapy to stabilize physiological parameters such as O2 sat, including vital signs and oxygenation, minimize patient to mechanical ventilator asynchronies like in your ARDS patient, minimize or prevent coughing like with your patient who has increased ICP. So they can even minimize or prevent extraneous physical movement with paralytics, like I said, with open abdomen, open chest, those kinds of things. So succinylcholine, it has only 2 approved uses in the United States, and it is the only depolarizing neuromuscular blocker. And those 2 uses are endotracheal or tracheal intubation to begin mechanical ventilation, or ECT therapy. And succinylcholine is contraindicated in patients with glaucoma, and as I stated earlier, patients can develop malignant hyperthermia as a result of succinylcholine administration. I actually have a pretty good article on succinylcholine. If you're interested, just shoot me an email and I shall send it to you. So there are some conditions out there that do prolong the effects of succinylcholine because they have low levels of the pseudocholinesterase in their blood. Pseudocholinesterase, if you remember, is actually responsible for removing succinylcholine from the blood. And these conditions are anemia, dehydration, patients who've had exposure to neurotoxic insecticides or other cholinesterase inhibitors, severe liver disease or cirrhosis, high potassium, malnutrition, pregnancy, recessive hereditary trait, and that's again talking about that malignant hyperthermia, certain genetic phenotypes. So, not that you don't know this, but just a caution, after therapeutic paralysis begins, your patient's going to be able to not breathe independently, and they will not be able to communicate with you, the nurse. We must make sure that we are monitoring their vital signs frequently. We must make sure the alarms for their vital signs are on and that the pumps are working appropriately as well, because Nimbex can cause hypotension and bradycardia, and you will want to know when that happens. So make sure that your alarms are on very appropriately. So the FDA labeled indications for your non-depolarizing neuromuscular blockers are adjunct to general anesthesia, to facilitate intubation, relaxation of skeletal muscles during surgery, relaxation of skeletal muscles during mechanical ventilation. These are the non-depolarizing neuromuscular blockers. Vecuronium is not one that we use in the ICU. However, LifeFlight does have it in their arsenal of medications to give to intubate. Vecuronium is one that we use quite frequently, and Nimbex is one that we use quite frequently. We used to use pancuronium many moons ago, but don't really use that, or the aterocurium either. Vecuronium has an onset of about 1 to 1.5 minutes, maybe why LifeFlight prefers to use that. Duration is about 30 minutes. They have a half-life of 60 to 70 minutes. So let's think, what do we mean by half-life? And when you think about it, that actually can last quite some time. Vecuronium, it's 2 to 3 minute onset, so fairly rapid onset. Duration lasts about 20 to 40 minutes with a half-life of 50 to 80 minutes. Nimbex, the onset's about 2 to 3 minutes, and there's a duration of 25 to 90 with a half-life of 20 to 30 minutes. So Nimbex has a much shorter half-life than Vecuronium or Vecuronium. Vecuronium, it's eliminated in the renals or fecal matter. It can be associated with dysrhythmias, transient hypotension or hypertension, tachycardia, or bronchospasms. Because of its rapid onset, some physicians do prefer to use Vecuronium versus using Succinylcholine for rapid sequence intubation. Vecuronium, this is one that we should be very familiar with. It is eliminated in your kidneys. It is eliminated through your biliary system. It has very minimal effects on heart rate and blood pressure. However, if you've got the patient who's in renal failure, this is not the medication to give them. Compared with other blockers, Vec has been associated with a prolonged effect after being discontinued, so kind of need to be aware of that when we're turning it off. Nimbex is actually eliminated through Hoffman's elimination, so it's not actually eliminated through an organ system. It is eliminated through an enzymatic process that occurs when there's a change in pH of the drug. So it's then eliminated. Like I said, this would probably be a better patient for your renal failure patients, but however, it does come with some adverse effects such as bradycardia, And I have actually had a patient on a Nimbex develop bradycardia, hypotension as well, and actually the patient ended up coding shortly after the paralytic was initiated. The patient was in ARDS, and so this patient actually did have a 7th floor discharge. So when I say, make sure your alarms are appropriate, make sure they're appropriate. Adverse effects such as flushing, bronchospasm, rash. Need to be aware of all of these effects. I'm not really going to go over this one because it's not one that you're probably going to see, but again, it would be appropriate for your renal patients. And pancuronium, it actually has stable hemodynamics and it's very cost efficient, but typically I have not seen this administered. So there are conditions that will antagonize your neuromuscular blockers. What do we mean by antagonize? Well, so your patient will need higher doses of your paralysis. One of them is high calcium, multiple sclerosis or demyelinating lesions, similar type disorders, diabetic neuropathy, polio, infections, and muscle trauma. It's very important to note these conditions because, if you have the patient and you're like, well, their train of force 4-4, 4-4, 4-4, and they have an infection, then you very well may need to go up on your paralytic. On the flip side of that, there are conditions that will potentiate your neuromuscular blocking, meaning that you need less of the paralytic, such as respiratory acidosis. I mean, we never have a patient with that, right? All of our patients have respiratory acidosis. They all do, and these patients need less of a paralytic amount than a patient who does not have respiratory acidosis. Other conditions, metabolic alkalosis, electrolyte abnormalities, which when you think of it, how does the non-depolarizing neuromuscular blocking work? Well, it works off the action potential and by not allowing sodium to initiate that. So conditions like hyponatremia. Don't have that much sodium in there to begin with. You're not going to need the blocker to help out with that. Hypokalemia, hypocalcemia. So these electrolytes are needed for muscle contraction, and if you already have low levels of them, then you don't really need that much of a paralytic to prevent the muscle contraction. Certain neuromuscular diseases such as myasthenia gravis, ALS, and muscular dystrophy. Neoplastics conditions like Lambert-Eaton syndrome, or everyone's favorite, hypothermia. If they're cold, they do not need as much of a paralytic as a patient who is normothermic. So there's also medications that can increase the effects of your paralytics, such as vancomycin. We give a lot of that, right? Procainamide, which is an antidysrhythmic, metoprolol, cardizem. So your beta blockers, your calcium channel blockers, your diuretics, your magnesium, and also steroids. So if you think about it, all your patients that have come in and they're post-cardiac arrest, then these patients are no doubt, if they've had a significant cardiac history, probably on a beta blocker or calcium channel blocker. There are also drugs that decrease the effects of your neuromuscular blockers, phenytoin, theophylline. neostigmine is an acetylcholine esterase inhibitor, and it actually can be used as a antidote for your non-depolarizing neuromuscular blockers. Remember earlier I was talking about there's a long story as to whether succinylcholine can be reversed or not. It can if, one, it was given at higher doses and it was given over an extended amount of time. You can go from being a depolarizing neuromuscular blocker to being a non-depolarizing muscular blocker. So it changes categories. So when it changes to that non-depolarizing neuromuscular blocker, you could potentially use neostigmine to reverse the effects. However, neostigmine has been shown not to work very well on the neuromuscular blockers, the non-depolarizing ones, because if you don't know how far paralyzed they are, it is hard to dose the neostigmine appropriately. Anyway, so that's a real long answer to that question. Sorry. So, alrighty, let's go to the next topic. So, your train of four. Your ulnar nerve. So there's been like a lot of heat I've caught about this particular topic, but the train of four should actually be done on the ulnar nerve. It is actually the preferred site of choice. This is clearly documented in your AACN procedure manual. Why is that? Because the ulnar nerve is very close to the skin surface. So what you would do, place two electrodes, find the bend in your wrist. Put one electrode just next to that fold, and then go about 1 to 2 centimeters from that and place a second electrode following the ulnar nerve up. And so here is the thing though that is extremely important. You must get a baseline. And when you get a baseline, what you need to be looking at is actually thumb adduction. So you need to look at your thumb, not your pinky, not your ring finger, your thumb, and see how many times your thumb twitches. So when you're getting your baseline, when you get 4 thumb adductions, then that is your baseline. Because just having the pinky twitch once is not, that's not a train of 4. So, you know, we don't count finger movements, we look at the thumb. Train of 4 posterior tibial nerve. It can be used as an alternative site when the arms aren't a good choice. You put one electrode 2 centimeters posterior to the medial malleosus, and then place the second electrode about 2 centimeters above the first. And what we're looking for here is the great toe for curling, plantar flexion, and we're going to count the number of toe twitches. On this particular site, correct placement is absolutely crucial, because if you put the electrodes directly on a muscle, then you're directly stimulating a muscle. Alright, so this is what proper placement of the train of 4 for the facial nerve is supposed to look like. Every time I've been up to the ICU, or several times, I kind of see it on the forehead, and truly that is not where it's supposed to go. My first preference would be for you to use the ulnar nerve. Second preference would be the facial nerve. You're going to put one electrode on the face at the outer canthus of the eye. So find your eyebrow, and it's going to go right next to the eyebrow, the bottom part of your eyebrow, or the outer canthus. Then you're going to place your second electrode about 2 centimeters below or parallel with your tragus of your ear. Now, this mannequin does a nice job of demonstrating that, but this gentleman also has a fairly large face. Most people do not. So we're going to observe the eyelid, not the eyebrow, the eyelid for twitching that appears like a wink. I can tell you during care camp I had this apparatus on my face, and Chelsea had it on her face, and when you put it where AACN says we should put it, it absolutely is quite significant what you can see. So the eye twitches very largely. The face even has some twitching going on as well. So here is a picture, or two pictures rather. This is actually where the facial nerve sits. So by putting the electrode outer canthus, outer, or not outer, but tragus of the ear, we can better stimulate that facial nerve to get a better response. There are nerves in the forehead, but the facial nerve is very large and it elicits a greater response. It's also easier to find than using the forehead for the train of four. I mean, seriously, you just use your landmarks. Where's your outer canthus and where's your tragus? Just a couple of notes. Because your facial nerve is more centrally located, it actually will recover from neuromuscular blockade more quickly than the ulnar or the posterior tibial nerves. So let's think about that. So your facial nerve will recover faster. So your peripheral nerve that you're thinking, oh, I only got a 0, it actually takes longer to recover. So, you know, you're getting a 0 of 4, well, leave it off longer then. You know, sites should be free from edema and hair, and yes, edema can absolutely affect your train of 4. If you need to remove hair, make sure you clip it, not shave it, because this alters skin oils. Typically, milliamps should be 20 to 50. Can be as high as 80 though. On our train of 4, some of them have like 1, 2, 3, 4. So 1 equals 10 milliamps, 2 equals 20 milliamps, 3 equals 30 milliamps. And again, make sure you get a baseline before you get a paralytic. Honestly, paralytics are not emergent unless we're doing a rapid sequence intubation. There's no reason that before we initiate hypothermia protocol, we can't get a baseline train of 4. Also, the baseline should be communicated to the next shift, and we should always use the same site from shift to shift to shift. And communicate changes. My baseline was a 20, now it's a 30, or anything like that. So why do we care? Well, by not getting an accurate train of 4, we could potentially be overshooting the level of blockade. And this leads to prolonged paralysis and prolonged muscle weakness, longer length of stay, you name it. If you give them, like let's say you just automatically turn your train to 4 on 80 and your baseline was actually 40, this overstimulation can actually result in repetitive nerve firing. So you're thinking the patient's twitching 4 times, but you're actually overstimulating that nerve. And then, so what exactly do the number of twitches mean? So if you've got a patient who has no twitches, that means 100% of their receptors are blocked. If you have a 1 of 4, you have 80% of their receptors blocked. 2 of 4 is 85%, 3 of 4 is 80%, and 4 of 4 is 75 or less percent of receptors are blocked. I don't know if you were aware that in Quest there is a drug order for Nimbex, but there's not a whole lot of guidance along the way. So if you look in Forms Fast, you will see something that looks like this. Make sure you have your train of 4, make sure you have your BIS monitor. The goal of the BIS is 40 to 50, and just so you know, Precedex is actually very inadequate sedation for use with Nimbex. Why? Because we all know Precedex is kind of like a little conscious sedation, so I don't think I would want to realize I can't breathe, but only be consciously sedated. You're going to obtain a baseline train of 4 as per protocol, and with that being said, every 15 minutes after the Nimbex has been started, you are going to check a train of 4 till you get 1 of 4 to 2 of 4. And once you get the 1 of 4 to 2 of 4, you can then assess your train of 4 every 2 hours. And yes, it's every 2 hours, not every 4 hours. If you get a 0 of 4 train of 4, then you should stop your paralytic. And then check again in 15 minutes until you get a 1 of 4 or a 2 of 4. And then you can start your Nimbex. Vecuronium, it actually has a protocol as well in Forms Fast. Not going to spend too much time reviewing this because it says the exact same thing that Nimbex does, except they've got Vecuronium in the place of where Nimbex was. Alright, so we're going to talk a little bit about BIS is it. So the BIS index is a processed EEG parameter. So the BIS monitor is just essentially an EEG continuous monitor. They get it from multiple advanced signal processing techniques. The algorithm for the BIS enables the optimum combination of EEG to a reliable processed EEG parameter. So it gives us what we call the BIS index. The BIS index value can range anywhere from 0 to 100. It's updated each second during patient monitoring. It usually is derived from the patient's EEG that was recorded during the previous 15 seconds, but it may go as far as 1 minute. The BIS index is scaled to correlate with important clinical endpoints and EEG states during administration of another anesthetic agents. BIS values near 100 tell us what? They tell us that the patient's in an awake clinical state. A value of 0 is the maximal EEG effect possible. 0 represents an isoelectric, or if this was cardiac, a flatline EEG. Patient movement can occur at any BIS value, so this is important to note. Even values 60 or lower, the patient can still move. Sedated does not mean paralyzed. A BIS value of 80 represents reduced memory function. At BIS value less than 70, memory function is markedly impaired. A value of less than 60, the patient has an extremely low probability of consciousness. So, according to the company, a range of 40 to 60 should be adequate enough for general anesthesia. And for our hypothermia protocol, our goal is 40 to 50. At lower BIS index values less than 30, the degree of EEG suppression is the primary determinant of the BIS value. A BIS value of 0 occurs with detection of a completely isoelectric EEG signal. So the next few slides are going to demonstrate that how the BIS index correlates to the patient's sedation state. One study showed BIS values were closely associated with a reduction in brain metabolic activity. So we're going to look at the next couple of slides that are actually pictures of PET scans. So if you look at this, this patient has a BIS of 100. Off to the left, the red is very metabolically active, and the navy on the right is less metabolically active. This is what a BIS of 66 looks like. So let's go back. This is 99. Nice, colorful, yellow, green, red. And so a BIS of 66 looks quite drastically different. There's a lot of that dark navy blue there, and a lot of blue in general. So the patient's brain is dramatically less metabolically active. And just 4 points later, at 62, we have quite an increase in the darker blues, and it's only 4 points difference. And this is what 34 looks like. The whole brain, except for a couple of spots, is actually navy blue. Factors that can decrease your BIS include neurologic injury, of course, cerebral ischemia, encephalopathic states, neuromuscular blocking agents in of themselves. Of course, if you administer sedation and analgesia, your BIS score will go down, sleep, or even hypothermia. Factors that increase your BIS, noxious stimuli, saying there's a lot of people in the room chit-chatting, REM sleep, seizure activity, shivering, and environmental noise. If you can, and you may not be able to, getting a baseline train. A couple of interesting studies I'm going to talk about here. The use of BIS in early detection of brain death. So what they found was if the patient's BIS value was 0 and their SR or suppression ratio was 100, then they could find the diagnosis of brain death. 24 patients actually participated in this study. They had a wide variety of injuries. Intracranial hemorrhage, 54%. Others experienced an ischemic stroke at 29%. Subarachnoid hemorrhage was 29%. Another study, BIS guided anesthesia. They used BIS after surgery in patients, and they had two groups: a control group that didn't have the BIS, who was getting propofol, and the other group was getting propofol, and they had BIS monitors on, and they found that propofol use in the one group was decreased by 21%, and that delirium was actually a lot less in the BIS group. So I'm going to talk about a few abbreviations that the BIS will give you outside of the BIS number. SQI, stands for Signal Quality Index. What this tells you is how good are those numbers you're getting from the EEG. The higher the number, the better. If you got 100, it's telling you your signal is 100% quality signal. It measures the overall signal quality. It is based on artifact, impedance data, date, and other variables. You'll also see a number called EMG. This tells you how much power the device has. It's measured from 70 to 110. It contains power recorded from the forehead muscle, activity beneath the BIS sensor. Suppression ratio, I made reference to this in one of the studies earlier. It looks at the EEG over the last 63 seconds. It indicates the amount of time that the patient's EEG was isoelectric, meaning flatline. So for example, if the SR is 80, then that indicates the EEG was isoelectric for 80% of the time over the last 63 seconds. EEG suppression is also a sign of deep anesthetic effect. So this is, and try not to get too caught up in this, off to the left is our BIS charting. You can see BIS, you can see SR, you can see SQI, you can see EMG. And then off to the right, that is a propofol drip that got started on this patient, supposedly at 9 p.m. for a BIS of 37. So we know that 40 to 50 is the goal, but our patient here had a BIS of 37 and propofol was initiated. Other times to look at, 11 o'clock there, BIS is 19. Midnight, BIS is 18. So the long story short of this, if we look at very top of the screen, 2 o'clock, BIS is 37, SR is 65. So that means that the patient was isoelectric 65% of the time in the last 63 seconds. An important concept for BIS monitoring is application of the forehead monitor. You know, I'm pretty sure everybody knows how to do it, but just a little review. Of course, it is numbered. You got 1, 2, 3, 4. Make sure that you are pressing the BIS monitor firmly on the forehead, and make sure that if you're having problems like diaphoretic patient or something like that, that you either dry the patient off, swab them with alcohol, or something along those lines. So that is it for this virtual lesson. We talked about train of 4, we talked about BIS, we talked about paralytics. If you feel like you need anything, just holler, and thank you very much.